All right, welcome back. So now we're at chapter 27. We have 3 more to go. This one's kind of a little smaller, so that's good. Hyperandrogenic disorders. If I could talk, we'd be doing good probably. All right. So get rid of my screen down here so I can have room to talk. All right. So usually polycystic ovarian syndrome with this. So a lot of patients, of course, whenever you see patients come in, usually what occurs 6 to 20% of all women, 70% with hirsutism, acne, right? Kind of that picturistic kind of PCOS patient, right?
Right.
You said the alopecia, we've talked about that, menstrual irregularity, when they come in and say, I can't get pregnant. We always want to rule out PCOS in patients.
It's becoming more and more common now than whenever I first got out of school. So a lot of women come into my office because of this, and many times it was found in the primary care. So
coming to you
with the hirsutism, the acne, you think about the higher male hormone that we have in our body. It's because of the hormone axis is thrown off. And what I tell these women is like, you've got hormone. I want my hormones checked. It's like, you've got hormone. It's just imbalanced. And so, I mean, I can look at somebody who is 100 pounds overweight. She may have a little acne, but you can maybe see where she has shaved to hide the chin hair, or even the prominent sideburns.
Like masculinity.
Yes, masculinity. Yes. And then the thinning of the hair up top. And you pretty well know that her periods are not going to be regular or non-existent. Many times it's non-existent, but you can't always think about that. It can still be regular, a lot heavier typically whenever they are having regular periods. So they don't always fit in this scenario. Yeah.
Textbook.
Yeah, exactly.
Right. So let's see. So ovaries, most common source of increased testosterone and androsten. I can't talk. Okay. I can't. Yeah. Whatever that word. Yep.
The androgens.
Yeah, the androgens.
Yeah, exactly. So this is just like I say, the estrogen and the androgenic hormone. So we in women have several estrogen in our body. We have the progesterone, but we also have a small amount of testosterone. And the more estrogen we keep in the body, so the reason why a woman who carries a lot of weight is more at risk is because the estrogen lays in the exogenous fat. And that's what throws it off. So as a woman, if she is inclined to lose weight, she loses less estrogen, which in turn begins to even up her axis. Yes, exactly.
That makes sense.
But by the time that they see us and they have PCOS, that weight loss seems impossible to them.
Yeah, I can see that. Yeah. Right. All right. So these patients, I think we've kind of already went there, right? Clinical presentation. So you have terminal hair growth in women,
so I'll ask them, they may not have chin hair, or hair loss, but I'll ask them so do you have hair where you don't want it, say around your breast or your nipples? Do you have heavy hair growth around your belly button or a lot of hair around your upper thighs?
Yeah, there you go.
So, I might, break that ice, or even on their glutes, they may have hair growth there. So I'll break that ice with, do you have that? Because it's pretty common. Yeah. Because they're embarrassed.
All right, and there's acne, of course, being able to see that and differentiate between what's
what's normal and natural versus what's maybe PCOS.
Exactly. What else? So virilization,
clitoral hypertrophy, that really is due to overproduction of testosterone.
Yep.
And I've seen that some, but that's not real prominent that I've seen. It's more of the hirsutism, the deepening of the voice some.
Not
You can
always,
tell,
a little bit, yeah.
no, but you can tell sometimes the shape of a woman by her, if she's got more of a muscle mass.
Yeah.
She's had more
Yeah.
more testosterone
Breast
in her body.
atrophy, like
Mhm.
more, yeah,
Yeah.
that makes a lot of sense.
And there's not much that can be done by the time they have the male pattern baldness. There's not much that we can do to reverse those changes. So I mean, yeah.
Wow. So it says half the patients, there it is are obese, and you kind of explained the pathophysiology surrounding that with how the estrogen likes to go to that area where there's increase.
And the same thing with the insulin resistance. If that pancreas is having to express more, eventually it's going to happen.
Exactly. And dyslipidemia found in women as well, which kind of coincides with all of that. So makes them risk factors are cardiovascular disease and diabetes, which makes sense. Depressive disorders, right? And that makes sense too, because they're having these mainly features.
Right.
So I can understand that.
In the metabolic syndrome, you'll oftentimes see that real darkening at their neck or around the creases. You'll see that.
Yep. That is so true. So increased risk of developing endometrial cancer.
Absolutely.
So we can't forget
just like
that.
I said, and that's a big one. Just if in your practice you're not you've not been taught how to do it endometrial biopsy, please send them to us, because that's one thing that can be prevented is endometrial cancer, but they're certainly at risk for it.
Absolutely. So history. So in our assessment, we want to make sure we get a bunch of details, right? Anything else that you would think about adding to that?
No.
Okay. So
it's
physical
thorough.
exam, measuring the waist, is that so BMI essentially?
Yeah, it is, and you'll find that axis is really thrown off there. They've got a large waist circumference.
Right, and all these kind of make sense.
Yeah,
thyroid, breast exams,
absolutely.
skin exams.
They go hand in hand.
Yep, and there's all your diagnostic testing, anything out of the normal for that. All of that kind of coincides with what we're looking for essentially.
Yeah.
So even looking for Cushing's syndrome right there because of the hormonal imbalance.
Pelvic ultrasound, I was telling Michelle that in some cases there are women who have, one thing I want to say with that may have PCOS, that it's usually your heavier women who are prone to that. But I have a few patients in my office that are thin, and they have that PCOS, which makes no sense, but it still happens. And usually in those women, we'll find evidence of maybe a slightly enlarged ovary on an ultrasound, that she may not have a cyst per se, but she has slightly enlarged ovaries, because we know what the average ovary measures. And that can be measured. And then we put that she may not have regular periods. She might have some acne. She may not have hirsutism, but with her ultrasound, we can see she has evidence of PCOS.
Great point. That's such a great point. So making the diagnosis, no single diagnostic. She just said that. You can't, it's like she already knows what the next slide is. I don't understand it. Seriously. So she's right. So she just said that, it just came out of her mouth. So no matter what, they may not be textbook, but once you put all of these pieces together and you formulate that puzzle, then that's when you can actually make that diagnosis of PCOS with this patient. That polycystic ovaries, you've done that ultrasound, you've seen that. Maybe not everything else applies, but you have a little bits and pieces, but there you go. Perfect. There's your differentials. I think you all can read that. We have to make sure we're looking at all of the above, essentially. Management, how do we treat these patients? Lifestyle, of course, you said, hopefully we've caught them at a point where they can have some weight loss potentially.
Yeah.
getting that hair removed, maybe like Lasix hair removal or
Well,
something maybe.
that truly is a great.
Yes.
If they have this chin hair, I mean, you can do it, you can help that by, with certain medications, somewhat. But if they can afford laser
Yeah, I've
hair
heard that.
removal, it works wonders. But somebody who is blonde or redheaded, it's not picking up the pigment, that's a waste of money. But
The dark hair.
the dark
yep,
hair
it
will
works.
be picked up. And so there's places in town that we can send these women.
That's great.
Yeah.
Right.
Yeah.
So combined oral contraceptives, you believe
Yeah.
progestins,
Right.
you agree with those, right? Okay.
Absolutely, absolutely.
Okay, and following up, of course, to make sure we're managing these patients appropriately. That makes complete sense there. When to refer, there you go. So
Mhm.
treatment for infertility. You had a patient that you were talking about,
Yeah.
sending off for
Yeah.
infertility,
Right.
if they do have issues like that. You always want to make sure if they're of childbearing age and they are wanting to have babies that we're looking into.
Yeah. So backing up to
Oh.
the management.
Yep, sorry.
One thing that we use a lot and primary care uses a lot is metformin.
Oh, good.
Yeah. Yeah. So the use of metformin, diet, low carb diet, and lifestyle change, many times you can get their periods back on track, particularly if they're wanting to get pregnant. So when primary care aspect is looking at, well, we don't want to, you might be pre-diabetic and we don't want that to happen. We
Right.
can put them on metformin.
The go-to drug.
But if they've not had regular periods and they're not using contraception because they've never been able to get pregnant, warn them when you put them on metformin, that can come. Yeah. But if you put them on some birth control, that kind of helps things as well.
Sweet.
And that way you're not worried that they'll end up pregnant, unwanted pregnancy, or end up with uterine hyperplasia or uterine cancer later. Yeah.
Gotta make sure.
I'm sorry.
No, I'm glad. I'm glad you saw me. That's great. Special considerations, adolescents, pregnant women, perimenopausal, the older lady, we always have to go there
Yeah.
for sure.
Yeah.
And there's your culture influences to make sure we don't forget that as well. All right. It's a rather quick one. So I'm going to pick up the next one. Chapter 28. All right. Benign gynecological conditions. So we've had great discussions surrounding conditions of the vulva, right? I mean, honestly, there's some unique things that we can find on physical exam. Wouldn't you agree? So you guys know what the vulva is. We won't go into that and what that looks like, what the patient's experiencing, like a lesion down there, symptoms. Are they itchy? Do they have pain? Are they complaining of burning or rashes or lesions?
How long have they noticed it? When did they first notice it? Because sometimes they right into my office, oh, found this, and it may be a very benign change, but they just noticed it, so that's another thing to ask them.
Yeah. So it's this definitive diagnostic is a biopsy, and we're going to talk about why, right? We're going to really kind of hit deep with that one. So what conditions are we talking about? There's skin cysts, and I think we kind of touched on this on another lecture,
Right.
how you can find bulls or cysts.
And let me just say something about the furuncles or the carbuncles. Yeah. They are very prominent. That happens. Oh, I've never had this before. It can happen. How can I keep them from happening? There's not a lot that you can do outside of wearing, avoiding tight clothing, that kind of thing. But most of the time it's the skin itself, their tendencies to have boils. And oftentimes you'll hear, well, my dad has boils other places, or my family has a lot of boils in life. So you can get it in the vulvar area. But more and more am I seeing women who come in and it's MRSA.
Oh my goodness.
Yeah. So if you've got somebody who you see and they've got a bull that happened quickly. It wasn't the slow, but it happened real quickly within a few days. And you look at it and it's like, oh God.
Yeah.
Yeah, that's
Yeah.
the reaction. Get a culture.
Okay.
Get a culture. You know, go ahead and treat, but
It's
get
not
a
gonna
culture.
hurt. Yeah.
No, because from time and time again, I'm getting those back as MRSA.
Wow.
Yeah.
Wow.
Yeah.
Hairs. Do you have a lot of issues with people
Yeah,
shaving?
you know, people, you know, even in the older clientele, they're shaving now. So, you know, it's either or.
Yeah.
But with the shaving comes more of embedded hairs or more cysts, more sebaceous cysts, just because of the skin process.
Yeah, I took care of a patient actually in the clinical setting who was shaving and had an ingrown hair and actually ended up, I guess, letting it fester for so long. She had to have it cut out and had to have it packed. Like it was bad.
Yeah.
So,
So,
and it
yeah,
was
that's-
MRSA too.
Yeah, and so just, you know, just be aware of that, and that can be treated in the primary care office as well as the gynecology office.
Absolutely.
But you know, when I've got somebody who looks like she's so tuned to herself, and I felt something here, and you can tell that it's going to be just, it's more a sebaceous process.
Yes.
It's not yet infected or anything. You know, I'll say hot moist compresses or sits fast. That's fine. That, you know, that will help to speed up this process. And you may not have to have an antibiotic. You may not have to have this lens. So go ahead and do that.
Right.
Yeah. So I had a lady who had folliculitis every few months and she was shaving. It's like, okay, if you're going to shave, that's fine. Just use a separate razor than you do your legs when you're shaving your legs or arms or arm axilla, and change it often. But if she still has this folliculitis, well, you might want to look at having it waxed or laser hair removal.
Yeah.
And that fixed the problem. Her going in and having it waxed.
Wow.
Fixed the problem because her skin, for whatever reason, liked the regrowth better than shaving. So that just kept, that was just something I've seen in my office.
It's amazing what you can get out of just asking questions.
Yes,
you know
exactly.
what I mean? So that's important.
Because it's not always a done thing. And some women may be new to it,
right,
but they think they're supposed to do it.
Right. Truly. What about hidradenitis suppurativa?
So we see this a whole lot. If it's here, it's in the growing, it's in that area. And, you know, sometimes a surgical referral has to be done, but that is one of those things you cannot do a whole lot about, other than just supportive therapy.
I can see that.
Yeah.
So there's some dermatosis, non-infectious inflammatory, like the contact dermatitis, of course, and the lichenoid disorders like the sclerosis planus. And we're going to dig into those.
Yeah.
Right.
So I see a lot of contact.
Good.
Oh yeah, because Bath and Body Works, you know, people, so that's a big one. Feminine hygiene products.
And there's tons out there. Yeah. Oh my gosh.
There's stuff on the internet, and so question that: have they changed soaps? Have they, you know, what are they putting on? Because oftentimes they end up with being sensitive.
And
just
you'll
like
you'll get anything, right? Because you told me that you even had a patient who went to Night Secrets and got some sort of
anal ease
to go,
which happens to be some form of lidocaine. Okay.
So seriously, and so you'll be surprised at what you get from these patients. See, she's got great rapport with her patients. They tell her anything. Yeah. Okay, so
and now I can say, ooh, behind the mask. Yeah. Are you serious?
Exactly.
My eye contact part is, I'm still working on.
See, I know that's my thing. You can always see what I'm saying through my eyes. So irritant, there's that again, irritant contact dermatitis, allergic contact dermatitis, of course, there's different.
So just by eliminating products, you know, if they avoid soaps, avoid anything perfumed, even what they're washing their clothes and drying their clothes in has to be considered, just like you would any other contact dermatitis elsewhere.
Totally.
Yeah.
Yeah. There's our lichen sclerosis.
I see it. I looked this up one time to see the incidence of this, and it was 1 in 80 women. And I dare say that's not correct information.
I would agree with you.
Because I see this 2-3 times a week, maybe not new cases, but women who are dealing with it in my clientele.
Yeah.
And so
hence
I see
the chronic
this often.
there. You see
Exactly.
benign chronic progressive disease.
Right. They need to know it's chronic too,
Yep.
because they don't believe me when I say you're going to have to treat this now ongoing.
Yep. And it may look better in a couple of days, but guess what? It's going to be back.
Mhm.
So there it is. So you can see it's a figure 8 depigmented formation that surrounds the vulva.
Yeah.
Looking at pictures of this really kind of hits home of what this looks like.
Or
Honestly.
the hourglass. That's oftentimes the
Yes.
term I use in my practice, the hourglass.
Yes.
But it's, and they may be in, I have diagnosed this without them even feeling anything.
Yeah.
They may not have realized that they had these hypopigmented changes.
Right.
Yeah.
Right. I don't know who puts a mirror down there and kind of checks out there.
Some do, most don't.
Most don't.
Yeah.
Yep, exactly. So lichen planus, inflammatory condition of the vulva, scalp, skin, nails, mucus, membranes.
So when you're doing your differential and you see changes of the vulva, you might ask them, has the dentist ever said anything with as far as your gum? Do you have any problems there? Anywhere else that you're experiencing that you're having to go to the dermatologist for? Because you can get lichen planus in the mouth and of the vulva, and of the scalp. But so I don't look at scalp, but that is true. But also lichen sclerosis can occur anywhere on the body. Mainly with me, I'm seeing it of the vulva.
Mhm.
And I really see more lichen sclerosis than I do planus. But the interesting thing when we come to how to treat that, you're going to treat it the same way.
Okay, perfect. Now we get to lichen simplex chronicus, localized variant. So it's a variant of an atopic dermatitis.
So
itch, scratch, itch cycle.
Yep. So once you figure out that's what's happening with them, you have to stop it with the steroid ointments or creams.
Yeah, it's a go-to, right?
Yeah,
Psoriasis.
exactly.
I think we all kind of know what that looks like. That's the textbook plaques covered with silvery white scales.
And I do a ton of vulvar biopsies to give me the diagnosis. I had a case this week that was confusing because she also had herpetic lesions and chronic yeast because she was diabetic. So I was like, we're going to biopsy because I'd given her benefit of the doubt to try treatment. So she was back. And so I biopsied her and it was lichen sclerosis.
Wow.
Yeah. So
wow. What said that?
Don't
so
be
even
afraid
the
to biopsy.
even the herpes was active at that time?
Not active.
Okay.
It wasn't active. I had already diagnosed her with herpes
Mm-hmm.
a couple of months ago.
Yeah.
But she was taking Valtrex because she thought she had active lesions.
Because of the sensation.
Because couldn't see down there, she was taking that Valtrex. Yeah, and it wasn't helping us. Like, okay, that will kind of stop that viral load. So this is not, so stop the Valtrex. That's not going to help what's going on now. So she had 3 things that was a possibility.
Yeah, so look at the patient, right? All right. Now we're talking about the uterus and cervix. So cervical polyps is very rarely malignant. And then endometrial polyps.
So the polyps, we can see them higher up in the endometrial lining, up or closer to the fundus of the uterus, but we can also see them on exam that may be just above the cervix that's poking its little head out. So when you're doing a speculum exam and you see how to describe it, you see a little, maybe not flesh colored, but a red lesion that may be coming through the os of the cervix, take a small swab, and go around it. Because if you can get that swab around, it's probably an endocervical polyp.
Oh,
And you can easily remove that. They may bleed it for a short period of time, but you can easily remove that with some forceps
mhm.
and send that for a biopsy and confirm that that's what it is. They're usually very benign.
Wow.
If it's not, if you can't get that swab around totally the circumference, 360 circumference of that, then it may not be a endocervical polyp. It's something else.
Oh, okay.
Yeah.
Wow. All right. Here's the uterine fibroids. You see these, right?
Absolutely. See a lot of them, but the way, and sometimes you can feel these on your bimanual because of enlargement, or you think, oh God, I hope that's not an ovarian, because you feel it off to the side. But sometimes there's different sizes as well as types of uterine fibroids.
So let me tell you a story about this. So whenever I was a labor and delivery nurse, I actually had this patient that was in labor. This is, for real. And she was complete and she was pushing. And so we go down there and I'm feeling this, what we think is a head, right? And so then the more I'm like, this is not the head.
Yeah.
Like it's not the head of the baby. So I'm calling the midwife in and I'm like, because she'd been in there checking the patient. And anyway, it wasn't the baby's head, it was a fibroid.
It was a pedunculated
Yes,
fibroid.
it was. And it was the size of the head of the baby. No joke. So she had to go for immediate C-section because it was, of course,
Grapefruit size.
yes,
Yep.
hindering the baby's head from coming
Exactly.
down. And then whenever the doctor cut her open, he flipped that thing up on her abdomen, on the sterile towel up there. And I
And
was
you're
like,
going,
oh my God, it's the biggest thing I've ever seen. And the whole time the midwife thought it was the head
Mhm.
because it was pushing on the
Right.
cervix.
Exactly.
So that can be
Yeah,
true. Like I was like,
exactly.
oh my God. So anyway,
So
that's my
yeah,
story.
different kinds of fibroids.
Yeah.
Some are within the uterine muscle itself, which are called subseral. There's others that are in the lining of the endometrium, subseral, intramural.
There it is.
That's
Yeah,
what it is.
yeah,
Yes.
yeah.
And then there is
Inside the muscle.
some on the outside of the uterine body itself, but then there's those pedunculated, and they're hanging off, and sometimes you can feel those when you're doing but first thing that comes to my mind is, oh my God, that she's got an ovarian mass.
Right, exactly.
Right.
Because if you're
So,
going about, like
right,
if you're going
Right, exactly. But it certainly can be a uterine fibroid as well. But the way that we diagnose those are off of the ultrasounds.
Okay.
Yeah, they're more specific, and we can actually measure, see where they are, what part of the uterus is
Yes.
it, and is it going to cause some issues?
Okay.
Because most fibroids don't. The
I'm
ones,
shocked that this wasn't picked up on the ultrasound.
well, that's interesting as well.
You know what I mean?
Yeah,
And
exactly.
why it wasn't charted in her.
And it may
chart.
have been though that things that this lady might have grown. It had been grown because of the hormones
I've
of
heard that.
yeah, the hormones of the pregnancy.
And I heard it dissolves more than likely. That
it
whenever they
can-
have those hormones, and then
it can start to shrink the
Yes,
same way
yes.
with uterine fibroids after menopause, because you don't have that hormonal influence.
That makes sense.
Yeah.
Wow. Okay. See how cool? Look at that. I love it. So there it is.
Well, let me
See?
say one thing.
Oh,
One thing you need to be aware of, increases with age. So I've
there it
just told her that I've seen it as young as in the 20s, but I'm really looking for them in the 40s and as they get older, and prevalent in African American women is almost a given sometimes. With if they got heavy bleeding and you do ultrasound, it's not a surprise to find uterine fibroids.
okay. And right there's the symptoms. Look right there.
Mhm.
Pelvic pressure, pain, dysmenorrhea, dyspnea.
Yeah.
There's it is. You just said it. Diagnosis. We usually do an ultrasound. I swear she looks at these. I don't know. But rule out endometrial cancer. You agree with that?
So when I put these two things together, the ultrasound, that tells me what it looks like. If it's not clear, because we get a lot of ultrasounds, it's just not perfect and clear to us. Don't not do an endometrial biopsy if they're bleeding.
Okay.
That's not going to tell me much about a fibroid. There's usually not cancerous, but the lining is. So,
Right.
Now there is, in rare instances, cancerous uterine fibroids.
Wow.
In rare instances,
Wow.
but most often what we see are
Or
not.
not. Okay. Treatment options, do you agree with all that right
Mhm.
there? Medical
Yep.
therapy, surgery, stable in size during pregnancy? Well,
Mhm.
not necessarily.
That's right.
I've not seen that one. I'm just kidding. Decrease in hormone production. Okay. Menopause. Now, here's a fun topic, endometriosis. Right?
Yeah. So this is the lining of the uterus, the normal cells of the lining of the uterus that sometimes they have found that backflush through the fallopian tubes, and it implants itself in the pelvic cavity. So that's a weird thought.
It is weird.
But and they're not certain why this happens.
Yeah.
But they do find that women who do it can run the family. So family history sometimes is helpful in this when you're thinking about this as a possible diagnosis. Moms, grandmothers, on and on,
yeah.
sisters, whatever, consider endometriosis, but it is it microscopically implants itself on the pelvic cavity. It can be on the outside of the uterus. It can form around the ovary. And sometimes it clumps around the ovary called endometrioma. We can actually see that on an ultrasound. Most of the other endometriosis we cannot find on because it's so microscopic. They call this, so the way that we diagnose this is by a surgeon going through a diagnostic laparoscopy and seeing the chocolate spots. That's what they call them. So it looks like these brown spots that have adhered to the outside of the uterus, even on the bladder, on the tubes, the ovaries.
I've often heard it called like spider webs.
Yeah,
Would you
and,
agree with that?
Well, because they're not just these tiny implants, but they're causing scarring.
Right.
And so they're causing adhesions, which look like the spider webs when they're looking on the laparoscope. Yeah. So that's how it's definitively diagnosed.
That's right.
When there's so when moms come in, they think their daughter, because they had endometriosis, their daughter
That was
has
my mom.
endometriosis.
Yeah.
Then
my
there's
mom.
a great possibility that their daughter, if she's having these painful, heavy periods, debilitating symptoms, that's a very real possibility. That's what's going on.
Well, thank God I never had any issues. Now I've taken care of patients who have, and it's pretty sad whenever they have that pain, the painful stuff going on down there.
So, but that's how it looks like within the pelvic cavity. It can even adhere itself to the colon. In severe cases, they have to do resections. So when you suspect endometriosis, first thing we're not going to do is a laparoscope, but you're going to treat them hormonally. Yep.
So I think that's the next slide. Often asymptomatic, but it can be severe and debilitating. So there's all your symptoms. There it is. Dull throbbing, sharp pelvic pain, depends usually, right?
Mm-hmm.
There's histological diagnosis, requires a surgical biopsy for confirmation. You agree with that, right?
Yeah.
Treatment, expected management, medical therapy, and surgery.
We're going to treat though before I ever refer to one of my surgeons for diagnostic. And now there is some hormonal treatment that we can even give if we suspect. A lot of these treatments will put them in menopause, if you will, to stop that growth, if we can get the insurance to cover. But we're going to treat them with hormonal options first. If I have tried several different hormone options to control this painful periods, and I can't get their symptoms totally controlled, that's when I'm going to refer to one of our surgeons to consider a laparoscope.
Perfect. Perfect. So adenomyosis.
Adenomyosis is the endometrial tissue that's within the myometrium. And that's something else we cannot see on an ultrasound. However, what we can see sometimes is we know the typical length of the measurement of the uterus is 6 to 9 centimeters. Let's say you've got a pelvic ultrasound and her uterus is sized at 10 to 11 to 12 centimeters. Consider the adenomyosis as a possibility. The only time that we can definitively say she has adenomyosis is she's had a hysterectomy, it's in pathology, and there's adenomyosis seen when they are dissecting that uterus.
Okay.
But it is a major cause of the woman as she approaches menopause or 40 and above. That's certainly a major cause of heavy bleeding and painful periods.
Wow.
Mhm.
All right. So, so there it is. Dysmenorrhea and abnormal uterine bleeding symptoms. Endometrial biopsy, transvaginal ultrasound. You agree with that?
Well,
right?
with the vaginal ultrasound, we can see the consistency and the look and measurement of the uterus. Biopsy, just to make sure it's not cancer.
Right.
That's just to
Right.
kind of rule out.
I think
Now, the treatment
Yeah.
we do use, first line, is Mirena IUDs.
there you go.
Yeah,
Marina
because-
IUDs.
Because if we can control her bleeding and pain and get her through to menopause, beyond menopause, with delaying that, then after menopause, this is not a problem for most women.
So tell me about what about even patients who have had their ovaries removed or some sort of hysterectomy?
Okay. So more than likely, they're not going to remove the uterus without they're not going to remove the ovaries without the uterus.
Right.
So if you have a patient that comes in and she's had a hysterectomy, most of the time those ovaries are going to still be there if they left them. For a younger woman, they're going to allow her to keep her ovaries to allow her to go through natural menopause. So we're doing many because we can't get their for benign reasons, we can't get their bleeding controlled with other options. They may take out the uterus, leave her ovaries. Okay, is that what you're asking me?
Yeah.
Okay.
We talked about
Yeah.
possibly doing,
But they're going to try their best to prevent a hysterectomy, which is the last ditch resort
Right.
to controlling the bleeding. But sometimes comorbidities, sometimes they can't use the traditional ways of controlling bleeding, and this is their only option is a hysterectomy.
yeah, that's what happened to my best friend.
Yeah.
Actually, she ended up having to have a
Yeah.
hysterectomy.
Sometimes you
unfortunately.
don't have any other option.
Yeah. So sad. What about an ovarian mass?
So we see these, and sometimes we don't know that they're benign until they go in and remove them. But if we see the evidence of endometriomas, I've seen the serous cystoadenomas. I've seen all of these. Many times they're being taken out, removed, so that way they're out of there.
Right.
We see follicular cyst or enlarged cyst on the ovaries. We see this all throughout their menstrual cycle, and they may not realize that they have them, but we do see them. So I send a patient and she gets her ultrasound. I see a 3 centimeter simple cyst. That's normal. That is normal. Tell her it will resolve on its own. Yeah, it's a little painful right now, but you can use some NSAIDs to control the pain. And sometimes if you have a patient who feels the cyst every time she has a simple cyst, sometimes you can offer birth control pills, and that can help to prevent the formation of cysts. Not always, but in most cases it can.
Oh, wow.
They want to know, what can we do to get rid of the cyst?
Yeah.
Nothing. I mean, it just kind of has to resolve on its own. When I have a cyst that's bigger than a 5 centimeter cyst, then yeah, I'm more concerned about that. particularly when it's causing pain and it's not reducing in
Right,
size.
right.
Mhm. And you're always looking for torsion, and they can see that. I don't see it often, but that's one of those things. If they're in bend over pain, they're usually in the ER, but that's what they're looking for on the ultrasound is their evidence of torsion.
Yep, I can see that. So you've already kind of said this mass can range in size. So it can be little or big, like just like I talked about that patient, even though, you know, it's a fibroid, we're still kind of worried about it. So any there testing pregnancy test to rule out ectopic pregnancy. I could see that.
Yes. So yesterday I had a woman married. She's very close to, she is 50. I still have her on birth control pills because she's not yet menopausal. And she was having bleeding and pain of the left lower quadrant. So I still have to worry about pregnancy or ectopic pregnancy. So I did a pregnancy test and then did the ultrasound. So she didn't have this particular this particular lady. She did not have a cyst. Kind of thought that might be what was going on. Let me back up. She takes her birth control pills continuously, so she doesn't have a period to control her.
So she gets her week off.
Yeah.
Okay.
So she hasn't had menstrual bleeding in a long time.
Okay.
So when she had this bleeding, she's right in my office because this is so unusual to her. And one of the things that I did outside of a ultrasound and a pregnancy test is I swabbed her for vaginitis. And that was what was going on with her. She had BV.
See?
And I gave her systemic metronidazole, and she should get better with that. So,
wow.
But I had to think about ectopic. Could that be an issue?
Absolutely, 100%.
Because when you have pelvic pain and bleeding, that's the first thing I think of is ectopic.
Yeah.
Because that's like their
100%. It's got to be your differential. It's got to be sitting there, right? All right. Man,
and ovarian cancer, we do see some hard to catch, but if you have somebody with an ultrasound that says a solid mass, she needs to be worked up for ovarian cancer.
Oh yeah, I would have to agree. You kind of not be on.
Well, there we go.
If you didn't. Yep. See,
page.
You're all about it. I'm telling you, you have to. Yeah, warrants further. Absolutely.
Yeah.
Absolutely. All right. That concludes this one. We have one more, which is chronic pelvic pain. And we'll be done for these 2 weeks. So let's share that screen. Go up here and get rid of that one. All right, last but not least, guys, and I promise we will be done. So we're into chronic pelvic pain. All right. So always take a multidisciplinary, holistic approach. Makes sense. Okay.
More and more patients are wanting that now.
Oh, 100%.
So, you be open to that. We're so in tune to the Western medicine, but realize that more and more are using essential oils and acupuncture and chiropractor and herbs and supplements. So just be in tune to that.
Yeah, I think you got to continue to kind of look at that. All right, clinicians automatically focus on gynecological organs when a woman has pelvic pain. Is that true?
Yep.
There you go.
Yeah, they always think it's their ovaries.
Yep. There you go.
All
right.
And in most times it's
exactly. Pelvic pain. So here we go. Broad term, right? So can be acute, chronic, cyclic, non-cyclic. I think we've kind of mentioned some of these differentials with chronic pelvic pain in this whole day that we've had together.
Yeah.
severe adversely affects normal functioning, diagnosis cause. Okay,
Yeah.
making sure I'm reading all that.
Yeah.
So there's acute and chronic, right? So
Mhm.
acute less than 3 months, chronic lasting more than 6 months.
Mhm.
So that's kind of self-explanatory, I
That's
think.
very much so. So some of the sources of possible pain, pelvic pain runs with two sources, visceral or somatic.
Yep.
So that's a very, that cuts it in half right there.
Yep, exactly, exactly.
So visceral from the internal organs. And this includes the bowel.
Yeah, exactly, exactly.
The bowel, the bladder.
You can't forget that.
Yeah, and appendicitis and kidney stones. So it is, or even the muscles.
Right.
When
Right.
when we're looking at pain, muscle pain related to the pelvis, that's something that, so it's hard to pinpoint. I always tell patients when they come in with pelvic pain, let's chip away at it one by one.
All right. So here we go. We have two different types of pain: nociceptive pain, pain with a purpose, or neuropathic and pain without a purpose. So I guess you need to differentiate, where the source is essentially, right? Okay. So laparoscopic or endometriosis, adhesions, absence of pathological conditions.
So, of course, in my world, this hits a lot of the pelvic pain. Or let's say a patient has had a history of endometriosis. We've done a pretty good job of controlling her periods with either birth control pills or whatever may be the hormone. And she is back in my office and she's having pain with intercourse. I've more than likely have her, if I've got her on birth control pills, it's continuous. That's one of the best ways of controlling that type of pain, is preventing a period.
Right.
But nothing's helping. So my first thought is, okay, well, she has a history of endometriosis. We have to make sure there's nothing else going on, and it can cross over where it gets worse with those. And some of those cases, it can get worse even though I've been treating them with hormones.
Okay.
So at that point in time, that's when you're going to be looking or sending your patient for a gynecologist to be considered of a laparoscopy.
Okay, good point. What do these patients look like? So that pain in the lower abdomen, kind of classic, right?
So this more acute pain, right?
Pelvic region, yep. Acute pelvic pain, yep. May or may not be recurrent with or without related to the menstrual cycle.
So that's kind of, you need to find that out if it's related to their cycle or not.
And we've kind of talked about that already,
about
right?
the cyclic pain,
Yep. And they may not seek treatment until it just gets where it's debilitating, where they can't, do their activities they live in, which makes sense.
So there's what we normally see with the pain assessment.
Yeah. You have to do it, I think, with all pain assessments. You have to do old carts. Absolutely. Kind of the same thing. So take a detailed history, obstetric history, surgical history, screen for any kind of abuse, depression. Are they using narcotics, alcohol, recreational drugs? You got to factor that stuff in. And on physical exam, what are we going to do? How to do? Let's see.
I love the part where it says observe the woman's gait.
I was thinking the same thing. I was like, that. What is that?
Because many times they're sitting like this on your table, or you've seen them, they're very guarded as they walk down the hall to be groomed. That's a very real thing to keep in mind.
Yep. Tenderness guided vaginal ultrasound exam can improve pain mapping. So where's it actually coming from? Where's it originating from?
Yeah, exactly. And the doctors that read the ultrasounds oftentimes can pick up on that.
Right.
But performing a pelvic exam, just like I included the last time, I was just kind of seeing where are their pain. Right. Is it as soon as I touch their outside? Well, that tells me she's had pain for quite a while, because it may not be, she's already guarded. So that makes the exam very difficult. And it's oftentimes very confusing for the provider, because if you can't hardly touch her without her guarding, then it's going to be hard to know exactly where that pain is. So you have to be very patient with them. It's like, okay, I'm going to tell you everything I'm doing. I'm going to not touch you. It's just with my finger. And then you'll feel my finger enter your vagina. Okay, I'm not going to put any pressure. You're just going to get that. So sometimes you have to use the directed of how you're going to do with no surprises.
I would completely appreciate that as a patient, you know.
Well, and then you're gonna, or touch the bladder, touch the cervix, touch the uterus, or is it more vaginal wall pain?
Yeah, I've seen that before too.
Yeah, so that's more of muscular pain, or even nerve. It can be related to the nerve, but and so we direct that way. It could just be that the muscles are very tight.
Yep. So laboratory testing. How do you feel about all these? There's that pregnancy test.
Yeah. That's basically to rule out everything else.
Yep, exactly. Additional, here we go. Here's some diagnostic testing, ultrasounds, transvaginal ultrasound, CT.
And some of these things, because you do have to rule out that it could be the bowel, the ureter, it could still be kidney stone or appendicitis.
Of course.
Now, I'm not going to be doing all of this, but at least I'll know once I kind of rule out what I'm looking for.
Your area of expertise.
My area of expertise that, okay, you need to see a urologist or you need to see a GI.
That's exactly right. It's very important. Here's your differentials. I think table 31.1 does a good job of that. Evaluate characteristics of pain with is it gynecological, non-gynecological? We just talked about that. Have you rolled out your stuff? And if you have, you can send them on if you're just in women's health and that kind of thing. And the psychogenic pain, only after ruling out everything else.
So I've had that before.
Have you?
And so we don't have a lot of sex therapists or any providers that are on this, but that would be with a woman who has chronic pelvic pain, dyspareunia. She cannot have sex with her husband comfortably. And we cannot find any other reason for that pelvic pain. Sometimes that psychogenic pain is real. And so I've referred to, I've talked to some counselors.
That's great.
Yeah. So we have a counselor that has a private practice that comes into our office because women, a majority of, whether they're OB, whether they're old or young, need a counselor. So she comes in on certain days. And so I went to her and I said, I think it's a psychogenic pain. And she said, absolutely, she'll be able to meet that lady. Yeah.
That's great.
Yeah.
So gynecological issues, we've kind of already hit endometriosis and adhesions, ovarian remnant syndrome, that ovarian tissue that's left behind after or
had that happen one time, so it's a true thing.
Wow.
Yeah. You wouldn't think that, but it's possible that it can happen.
And then ovarian retention syndrome, the ovary is left on purpose after a hysterectomy. We just talked about that.
And that's the tendency, unless there's an ovarian source that they want to remove that.
Right. Ovarian hyperstimulation syndrome, pelvic congestion syndrome, and vulvodynia. Anything there? Kind of there.
Pelvic congestion syndrome is kind of new to us. They're seeing it on possible CT scans where they're seeing some dilated vessels and that kind of thing. I've heard this from urologists may sometimes be seeing that on even their CAT scans that they're doing. So not a whole lot that we can do about that at this point, but vulvodynia is pretty common. I don't want to say common. It's one of the common sources of pelvic pain.
Okay.
And it's very hard to know what to do with these things because it's hard to understand why women have pain of the vulva, even when they wear tight jeans.
Right.
So we have to get creative with how we treat that, like amitriptyline,
Yeah.
for instance, duloxetine, lidocaine. You can always do compounded things that sometimes will help, but it's really hard to understand because you can't see anything. So it's again chipping away, rolling out other things that could be a cause of vulvodynia. Vulvodynia is just the heightened nerve endings of the vulva that causes them chronic pain.
Wow. Wow. Non-gynecological causes. So we have GI stuff like IBS, musculoskeletal disorders, interstitial cystitis. That's one of your famous ones right there, and urethral syndrome.
Yeah. Just be in tune that there is also other reasons than the ovary.
Right, exactly.
That's causing
exactly.
that. Interstitial cystitis, that's something that can be, if you suspect that the source of pain is the bladder or the irritation of the bladder because of whatever's going on, just consider that as a source and either, refer your patients for a gynecological workup or to a urologist, because they work extensively with this interstitial cystitis. That's more of a woman affecting women. It can be affecting men, but it can affect a woman at any part of her lifetime.
Wow. Wow. All right. So a non-pharmacological treatment dictated by the diagnosis, manage pain if no pathology, physical therapy and exercises have positive results. There you go. Aerobic and non-aerobic exercises. All right. Pharmacological treatment, there's your COX-2 inhibitors, mild opioids, stronger opioids, hormonal treatments like combined oral contraceptives.
Always trying to stay away from opioids. That's just the trend right now.
It is.
We don't want to be sought out by the
no, we don't.
But certainly if you have a patient and everything has been done, you have sent her to all the experts and there's no found reason for her to have this pain, sending her to the pain clinic is worth
great
it.
option there.
Yeah.
There's your amitriptyline. You just said that, which is hilarious for neuropathic pain. And then maybe a combination of drug therapies may also be an option there. All right, surgical treatment. Maybe excision or laser ablation of the endometrial tissue. There's your hysterectomy and vaginal mesh.
And sometimes really and truly, you can't really find a cause. And sometimes for continuous pain, you've done CTs, you've done ultrasound.
Yeah.
Sometimes if they take out that uterus, it does fix it.
Wow. When all else fails, get it out. All right. So complementary and alternative medicine, your CAM treatments. You can read all those.
Yeah. And if you recall back when we were talking about the bladder and the incontinence, the acupuncture, it's real and it works.
It does.
Back with pelvic floor. So.
Yeah, and right there's that nerve stimulator. We talked about that too. Remember with the tibial nerve stimulator? Yep. So then we go into when to refer, and that's what we kind of already touched base on. We ruled out what you're doing in your area, and you think you need extra resources to send them out to them, and even that psychosexual counseling therapy is also an option.
Yeah, and some of this caught my eye.
Oh yeah, let's go. Current and emergent evidence for practice. We gotta love it. So what you got?
Diazepam. That's the only time I prescribe diazepam for pelvic floor pain. And
there
it helps.
You go. Really?
It helps. They have to be willing to use it nightly in the vagina, and we've got several people on that. So by having it compounded into a vaginal suppository, they're not going to take it otherwise.
Yeah.
However,
seriously,
you can use a vaginal tablet that you would normally take orally.
Put it up there.
Yeah.
Wow.
Yeah.
Gotcha. Well, what else? Anything else in there stick out?
No, not too many times.
Okay.
Am I doing the cannibal?
I was gonna ask that, but I was like, whatever. Should I go there or what?
No, we're not doing that. Well, again, there's that pelvic floor and yoga. Yeah, those are real. So nerve stimulation therapies, back to the IC, there is a urologist that is located in Winston, that when you know your patient has seen him, that she has terrible IC. He is the guru of IC treatments when nothing else is working, to the point where I've even got a patient who had her bladder removed because of the pain. Well, that's the only one, but yeah. So yeah, she wears a bag. But you know what? It took care of her pain.
Wow.
Yeah.
So interstitial cystitis, man,
It
I guess you
can
have
be
to be.
debilitating, but I just mentioned this doctor, and he's been around a long time, probably approaching retirement, and I'm hearing from my patients who go to see him. Now, he doesn't recommend removing the bladder, of course.
Oh, no, of
No,
course
but
not.
he does therapies like the diazepam,
Right.
the compound is the TENS unit, they call it E-stim. He's doing all of that to control their pain,
Yeah.
and their to be able to make it from day to day. But he's also teaching and prepping some of his residents that
Yeah.
he works with.
Well, I'm sure that was a last
to take
ditch
care of
effort
that. Oh,
to take
yeah.
out the bladder.
Oh, yeah,
I'm sure he's
absolutely.
went through all these.
But I just want y'all to realize that IC is a real source of pain. It's not all the pain, of course, of pelvic pain, but it is a real source of pain that should be considered.
We need not forget, right?
Right.
There's patient education. If y'all want to look at the appendix with that. Special considerations. Of course, I think we kind of understand what this looks like with adolescents and going through each patient population, rule out PID, pelvic inflammatory disease with your adolescents, women of reproductive age, looking at infertility, there's that, perimenopausal women, age is a risk factor, counseling younger women about their treatment options, older women, minorities, and there's your transgender and gender non-conforming individuals. So make sure you're looking at their pelvic pain and anything related to maybe even testosterone therapy. That's so important. So, and can't forget about culture. We're going to need to make sure that we're looking at those patients with the vision that we need to, right?
Yeah,
They
I
can
had a
express
learning
pain differently.
experience right before Christmas where it was a woman of a different culture as well as nationality who lives here permanently, and she had been bleeding. She lost her husband to COVID. They were middle-aged. She now solely owns a convenience store, and she has children that she sends to school. But with her husband passing away, she has this convenience store all the time. And she was going to be able to take a break to go back to her homeland over Christmas holidays. And she wanted to go to the temple. I think it was a Hindu. And she can't be bleeding when she went in the temple. So not knowing much of a lot, because we'll see a large clientele of this culture, I had to ask her, I was like, okay, explain to me what I need to do to help you. Basically, that's what I told her. And she said, if you can help me to stop bleeding so I can go to my, I haven't been in my temple for I don't know how many years. So I ended up giving her progestin. Of course, I worked up just a little bit, but to know that what I was going to give her wasn't going to hurt her, but I knew that it was going to stop her bleeding. I gave her norepinephrine for the time of her trip.
Wow.
I told her, I said, I will help you if you come back in and let me finish this.
Oh.
And so we can get a pap smear on you, but she didn't. She went to her temple over Christmas, and now I can't get her back in. So I contacted the referring office and say, well, I need help getting her back here. But that's the first time I've ever had that particular culture and ethnicity that I had to work around to help her be able to go to her temple to be able to worship.
Right. That's awesome. All right. That's it. So thank you guys for listening. I hope this has been really helpful. I want to thank Terry for helping us out with these modules. I really appreciate her experience in women's health, and I hope this has been very beneficial to you guys. So we'll see you next week. Take care.